So this starts with really an immune response and a presence of an AMA. And I see patients all the time who've had an AMA check for whatever reason. They either had a transient abnormal liver test, or I had one where the dermatologist sent it because they were itchy, and they had stone cold normal liver tests. And they ask, well, do I have PBC? And the answer is, I don't know. They may have pre-PBC, but we know that the AMA comes first. And if you have a patient with a positive AMA and normal liver tests, I tell them that you are probably at increased risk of PBC, but you've already met the endpoint of treatment. There's no purpose in doing a liver biopsy. It will be normal, but they need to be followed, because then they may develop an increase in alkaline phosphatase. With that, they have increased bile acid accumulation. Those toxic bile acids lead to inflammation and fibrosis. And if you find it when the bilirubin is abnormal, you've missed the boat. So what happens over time is bile duct loss. And as bile ducts are lost, cholestasis increases. It's important to remember cholestasis is bile acid accumulation. Bilirubin becoming abnormal is very late. So when in doubt, measure bile acids. I don't know how many of you measure bile acids regularly or ever, but if you've never ordered serum bile acids, put it in your armamentarium. So if I have a patient who's itchy and I think it's from their liver, measure their bile acids. If they're normal, it's probably not their liver. If it's abnormal, even with a normal bilirubin, they might benefit from bile acid resin or some other treatment. So if we look at, this is a disease predominantly of women, but men with PBC do worse. And it's been pointed that maybe it's due to the fact that they drink more, or maybe it's due to the fact that it's a different disease, or maybe it's due to the fact that they're diagnosed later. But the important thing is, from this slide, is not to me that men do worse. Look how badly both groups do. 2 years from diagnosis to death or transplant in 20% of patients. And that is the problem of late diagnosis. And so if you're seeing patients with abnormal liver tests, look for PBC early on, particularly if they have a cholestatic pattern. And then you won't have patients going to death or transplant. And the other thing that's important is that when your patients get diagnosed with PBC, they see this data on the internet from Dr. Google, and they think they're going to die in 2 years, even if they have no fibrosis. So it's important to also reassure them that early intervention changes outcome. That came up during the last Q&A, and I think Paul said it very well, but I'm going to emphasize it again. Treatment changes outcome. Period. We used to transplant patients for PBC all the time, and now we rarely do, because we intervene with treatment, because the prevalence is actually increased.